Thank you for the nice introduction. The silent windmill, I might start using that one in my work. So really happy to have a session on CMV in this meeting. I hope you welcome this topic. This is one of my big passions and in my career. So today I will talk a little bit about Ganciclovir PKPD, which is the main stay of treatment, and Professor Lungman after me will talk a lot about CMV treatment, so I will focus more on this drug. So briefly, for all the people who work on HIV and have kind of maybe do not see HIV anymore because our CMV anymore because of our HIV patients are not having this anymore. So this is a herpes virus that is highly prevalent in the adult population. So we do see IgG positivity. However, it does not cause severe disease in immunocompetent patients or people. But we do see that it's fatal in immunocompromised people. So there is still a big population of congenital CMV patients. HIV patients less so, as I said, but still that is a population that is affected by it. But the main group of population is our transplant recipients, so stem cell and solid organ transplant recipients who are having CMV disease and viremia. So what do we treat it with? Nowadays we have more drugs available. Again, for the next speaker I will not go into this, but Ganciclovir is really still the golden standard, and it's prodrug Ganciclovir for the treatment of CMV. And for many reasons, this is a really nice drug because, well, first of all, we do use it for quite long durations for prophylaxis. Nowadays, the Cytomegalovirus is also used for prophylaxis for stem cell transplantation, and it has shown to cause significant toxicity. So in some studies, even up to 50% of patients actually show neutropenia. And that obviously causes the patients to become even more immunocompromised, even more difficult to treat. Coming to why it's nice now, in pharmacokinetic sense, it is in a way easy to study because it is almost entirely clear to the kidneys, and the protein binding is 1 to 2%. So we are mostly measuring free drug concentrations. However, there are still very scarce exposure efficacy targets, and we have been investigating these for some time, and I'll show you where we have reached by this point in time. So this is a study from Hugh Wiltshire and colleagues that looked into pharmacodynamics of Ganciclovir, and this is an interesting study that kind of defined the AUC target of Ganciclovir for the decades to come, let's say, so because this is from 2005. And in that study, they saw less viremia with AUC of 50 in prophylactic patients. But what has happened at this point in time is that this target has been kind of pulled from this paper and doubled and used for treatment, and it's not really related to been related to treatment patients. So I have been interested in looking into this more. So this is a figure that is illegal because it has two y-axes, so I'm sorry for that. But on the left, you can see the CMV viral loads, and on the right, you can see Ganciclovir concentrations. I'm not sure if this works, yeah. But basically, the idea is that time and time again, we saw in Groningen, where I was doing my PhD, that patients started to kind of show resistance CMV, or we call it refractory CMV sometimes, that they did not really, their viral load didn't really come down. It was kind of fluctuating in it was kind of fluctuating like 40,000 copies. So there was a fear of resistance, and we did not see a resistant mutations emerge. So we tried to push the dose, and because Then we started therapeutic drug monitoring, and we saw that incredibly low drug concentrations were measured by, for example, for patients who have augmented renal clearance. So for several patients, we did see an effect of therapeutic drug monitoring and kind of pushing the dose higher, and the viral load would collapse until several hundred days after. So then we did a clinical study in around 100 patients, and we saw, which we could have predicted, a very high variability. So in this figure, you could see on the y-axis trough concentration, and on the x-axis the different ranges for kidney EGFR, so kidney function. So above 120, which we can, I really can't use this pointer. Above to 120, we would basically see there is nothing there. So basically, these patients are either need to be there needs to be some dose optimization happening, which we see in treatment group that the concentrations are higher, or we could debate that there is some drug probably inside the cells because this drug needs to phosphorylate. So we did correlate our trough concentrations to some safety outcomes. So we did see that the highest AUC concentration or AUC exposure does correlate to some safety outcomes, and the same for the highest trough concentration. Thereafter, we took all this data and we looked in. We were clear. Okay, we need to focus on patients with kidney function, and we need to determine the trough concentration alongside with AUC. So we really didn't see a good correlation between the trough concentration and the AUC. Thereafter, we developed a linked PK/PD model. This is a very messy kind of overview of the viral loads of all these patients or the treatment patients. I fitted this into a PK/PD model, and you can see here that basically some of the patients are very much fluctuating on lower limits of quantification because they don't really have severe viremia. However, after doing some simulations, we did see that on average there is a 1 log decline of viral load per 2 weeks. So that's quite slow. So we would want that to happen at least a week faster, let's say. So after this, it was clear we are not really certain that what is the target, and there is a gap of knowledge. We do see slow decline of viral loads under standard dosing for patients in our clinic, and we do still miss clear treatment targets. So what's next? So we basically went into the lab to look into these targets intracellularly, or in not actually intracellular yet, but in an in vitro model. And as you all probably know, studying viruses, we do need to use the host cell. So we use a lung fibroblast model where we studied a CMV infection. So my PhD student, Lalita Srajana, has done some great work on our infection models. Here is just a very crude kind of analysis of delaying start of Ganciclovir treatment, and we can see that when we start the treatment later, meaning the viral load is likely higher, we do see moving on further into the treatment, there is a less of a viral load decline. Here, Ganciclovir concentrations on the x-axis and a log drop of viral load on the y-axis. The day 10 we can basically ignore because this is more like an experimental artifact, because by day 10, if you start treatment on a static cell assay, you will have mostly dead cells, so there is not really useful to look at that then. So if we collapse this figure into a AUC, so if you look at AUC over time, and we try to correlate that to the viral load decline, then we do see that AUC clearly is the driver of the effect, and of course the cumulative drug effect leads to greater effect. Now, thinking about this model, we clearly have a lot of limitations when it is when we are dealing with a static cell model. So it's basically a drug. A time kill experiment. It has a lot of value in optimizing our models, but we are still missing some fluctuation in the PK, let's say. So that's why we are now working on the hollow fiber infection model. I'm pretty sure a lot of people know what that is, but just briefly, we basically set up this dynamic system where we can simulate then the clearance of the drug using the half-life of the drug. So we do get humanized drug concentrations, and we also have been able to show a humanized CMV growth in the cartridge. So now this looks really nice and elegant, and I don't have the picture sadly from Lalitia from all of these tubes and wires and kind of the system. And another thing is that thinking again that this is a virus, we need approximately 50 to 60 million cells per cartridge to actually do this experiment. So that's why we do quite a long series of static experiments first to really define the experimental design. And we do have also PK data, which I don't have to show sadly, that it does actually have a very nice humanized Cmax and Cmin concentrations. What we are working on now is to then start to fully fractionate both Ganciclovir and phosphokinetics drugs in this system. As I said, per arm, we need quite a extensive amount of cells, so that is why it's taking some time. So. And how do we then translate these results back? The question that I every single time get in every presentation that I give, what about the patient's immunity? Because in CMV, of course, it is very important to take that into account, and obviously also the response of the viral load decline. And what we do is that we collaborate with clinical centers and also, of course, in Leiden University Medical Center, where we work very closely with. And we correlate these targets that we define in the hollow fiber to clinical data. And moving on, obviously, we also need to start looking at the patient's immunity, what kind of immunosuppressions did the patients get. But the first very important step is to understand what kind of drug is it? Is it a Cmax drug? Is it an AUC drug? And we are really missing this for a lot of antivirals, I think. And I think that these are the first things that we really need to look at. Who will benefit from dose optimization? We still don't know. I recently was in a very nice podcast by Breakpoints. This is a Society of Infectious Disease Pharmacists in the US. And we had a really nice conversation, and actually interesting, if people are treating CMV patients, it is an interesting discussion, because in some centers what I understand is that the feeling, the anecdotal experience is that the toxicity of Ganciclovir is related more to the very long treatment effect. And if we have a CMV infection, an active viremia, an active infection, then likely doubling the dose for some days or week might be beneficial. So we don't do that in the Netherlands, according to me, but I've heard from some centers in the US that they do that, and of course they have lots more experience with the transplant patients. So it is an interesting conversation. So I am fast as usual. So take-home messages. PK/PD relationship still not well described for efficacy. So we are using the hollow fiber infection model for that now, and we are very much basing our estimations and linking that to clinical data. I don't have time to show that for now, but we are also looking intracellularly, so we are looking at the phosphorylation steps of Ganciclovir. We are also looking intracellular viral loads, so these are the next steps we are looking into. It's obviously very important for Ganciclovir as a nucleotide analog. So the AUC target that is quite broadly applied for this drug is actually known only for prophylaxis and also from kind of a post-hoc analysis type of study. The extremes of kidney function clearly will benefit for dose optimization. If you are afraid of toxicity or even not having a good enough viral load decline, then extremes of kidney function, we really see that they are having, in some sense, sometimes very limited concentrations, sometimes very high concentrations. We do recommend to measure AUC alongside with trough concentrations. And obviously, we need to consider the immunity of the patient when we treat CMV. So happy to take questions later. And I want to thank, I think I had a different slide in the end, but I had a collaborator slide. But thank you for my students, and thank you for all the collaborations that I have. Thank you.